Okay. This is another clip concerning narcosynthesis from a movie that was fairly popular in the early 60s called Captain Newman MD. Okay. And I'm just going to show it to you briefly to make the point that narcosynthesis was the mainstay of treatment up until about the time of the Vietnam War. Okay. And then it went extinct, really for no good reason, because I've done it myself using other agents, and it works just as well as the old literature said it did. Our process for picking and promoting a treatment is really highly irrational. You know, the treatments are memes, they're replicators that compete in something like an ecosystem, and unfortunately the utility for the patient is only one factor on a long list of other factors that mandates whether or not they're going to survive. Okay, and one of the problems we have in medicine is that ever since penicillin, we've been conditioned to think that the most effective treatments in medicine are the newly discovered drugs that are patented and made available at considerable profit and pretty high price. And older drugs and other treatments that don't fit this pattern are seen as being less effective. And so that, for example, when Prozac first came out, it was seen as the most effective, the best advance in treatment and the greatest drug ever. But when it ran out of patent, we began to find reasons why it wasn't such a good drug after all, that it had too long a half-life and interfered with other drugs and so forth. And let's see, could you move ahead just a bit? Now, and there are actually two forms of medication-assisted psychotherapy, which I think is kind of interesting. Go ahead and move it close to the end. Okay, so Bobby Darin almost got an Oscar for this role of overacting. And of course, here's Cary Grant and Angie Dickinson. And the slang term for amytal was flack juice. Okay, and you incrementally dose patients until you begin to lose the corneal reflex or they stop counting. And this actually, this is all of this supposed to be amytal. This actually demonstrates the other form of so-called abreactive therapy, the excitatory abreaction, that involved agents like ether that would actually produce emotional excitation and a flashback. And William Sargent introduced this back during World War II. And I have an interesting article from 1947 with Chauvin and Sargent where he talks about using this technique, that you would actually coach people into higher and higher levels of excitation. And Sargent said that it wasn't necessary that they have a true memory of the original trauma, that actually was often helpful to alter the memory, so that someone, for example, who had cowered in a foxhole while all of his buddies were killed by a machine gunner, they might be coaxing him into saying, now you get up out of the foxhole and you're running toward the machine gunner and you're firing your .45 and you're shooting and shooting and shooting and finally you hit them, and that this would have a reparative effect. Okay, so one spectrum or one component of PTSD symptoms is emotional conditioning that's centered on the amygdala. And we know most about fear because fear conditioning is a well-recognized animal model, but of course other emotions like shame and guilt and anger and so forth are components of PTSD. Now, I'm old enough that I graduated from medical school in 1982. When Joseph Ledoux proposed to study fear conditioning as a model of PTSD, PTSD as a term was just introduced the year before in DSM-3. There was, it had previously been called traumatic war neurosis, and I remember very clearly seeing a patient who'd had PTSD related to a car wreck and not having, in part of the common wisdom, a good explanation for what was going on with him. Anyhow, his first grant was turned down because the reviewers said that emotional memory was not an appropriate topic for scientific research. Okay, now luckily he persisted and largely mapped out the anatomy of fear memory. And one thing that's very interesting is with brain imaging that the anatomy interacts with the cognitive science, which then interacts with how we do the psychotherapy. So Sargent later came across a book by a Methodist preacher named John Wesley, who would do tent revivals during the 1700s. And he wrote a book called The Battle for Mind, where he called attention to the similar behaviors and physiology associated with revivals and ether abreaction and brainwashing, which was very prominent during the Korean War, where there was a gradual increase in emotional excitation. In revivals, conversion experiences, and an ether abreaction, there's a phase where the patient develops catalepsy. they lose their muscle tone and they collapse and they kind of shake their head and say, the things that used to bother me don't bother me anymore. And it's pretty clear that the sedative abreactions involving agents like amytal and pentothal and propofol, one of the things they do is they act kind of like a nerve block on the amygdala. They attenuate the intensity of the fear response, and they block the freezing that occurs when you trigger the fear memory. And they allow you to develop an extinction memory that displaces the original fear memory. And it's interesting to speculate that a different process is involved in the excitatory abreaction, but I'm going to come back to that later. So go ahead and take that off. I won't show you the rest of the clip here, mainly the point being that this was such a mainstay of treatment that it was featured in films at the time. And when I was training as a resident, I remember doing amytal, did it myself for treating so-called conversion symptoms like stuttering, but was completely unaware of the literature on using sedatives agents to treat PTSD. Okay, so the effects of trauma, PTSD is one, and again, it's not only just fear. Some patients will have other emotions, shame, anger, guilt, and so forth. We know a lot less about those emotions. Conversion symptoms, these are seeming neurological symptoms that are produced by trauma. I once saw a woman who had conversion blindness for 2 years. And she had been working at a time when there was considerable psychological stress related to both her work environment and her mother. And she had a wire go into one eye and became blind in that eye. And then when she lost her sight in the other eye, the ophthalmologist assumed it was the sort of spread of blindness that occurred. But in her amytal, she recovered the ability to see and was able to describe some of the, like in John Huston's film, some of the conflictual causes of the conversion symptom. Dissociation and numbing, the patients are besieged by extreme emotional waves of uncontrollable emotions, and the first thing we do is we try to stuff it down, and that's where the numbing and dissociation comes from. In extreme trauma, patients freeze. They may view their body from another position in the room, and there's this controversial diagnosis, dissociative identity disorder, that I think does occur but is much rarer than people think, that also can be a complication of the wrong type of psychotherapy. And then importantly, many patients who have trauma have it repeatedly growing up through a caregiver. And another component of PTSD, this so-called complex PTSD, is effects on the attachment system, which we know a bit about, much less about the anatomy and physiology of it. We know something about it. And this manifests itself as personality symptoms. Next slide. So I like the term facilitated psychotherapy, also called narcosuggestion, narcoanalysis, or amytal interview. Psychotherapy facilitated by either sedative agents and a sedative abreaction, or other drugs that are excitatory, used since World War II to treat conversion symptoms and PTSD. Rarely used today, despite clear efficacy and rapid response. I've tried to use this in the hospital environment in situations where it was clearly indicated and encountered very stiff resistance from other professional staff, and the reimbursement for it has not been updated for more than 30 years, so there's no incentive for anesthesiologists to be in the room, and our standard of care has moved on to it's no longer feasible legally for me to do it at the bedside with amytal like I learned how to do it when I was a resident. You have to engage an anesthesiologist, and they don't like to do things that they don't get paid for, so it's virtually impossible to do this. Okay, it can be done with propofol and other agents, and I had a little bit of experience with doing that. Next slide. This is the last large-scale study of so-called amytal abreactive therapy, and it's a really good study. 19 patients with combat-related PTSD from the Vietnam War. During amytal, combat sounds were played, and 14 out of 15 patients had abreaction, or 15 patients had abreaction. They had an emotional recall of the traumatic events, were able to vocalize what happened. And then at 1 year follow-up, 14 out of 15 of these patients continued to be free of panic and dissociative states, okay, which is remarkable. Almost complete remission in the patients that have abreaction, okay. This has been replaced by medicines like serotonin reuptake inhibitors that work less than 50% of the time and are frequently not used because of the avoidance behaviors that go along with PTSD. You can't, try to get a veteran with PTSD backed by the VA is a real challenge. And so there's a very high dropout rate, there's a time lag to response, and a very high non-response rate. Next slide. So I had a lady who had extremely severe complex PTSD from being tortured by both parents when she was very young. And she had a very severe bipolar mood disorder and was getting electroconvulsive therapy for this because everything else had failed. And the nature of her trauma was that she had many forms of trauma, but one form was that, and she's allowed me to talk about this. This is 20, 30 years ago and several thousand miles away, so I can talk about this. One thing that would happen was that if she had not completely cleaned up the house when her mother came home when she was about 8 years old, her mother would make her stand there with her arms out like this and would take a pin and would stick it into her arms. Okay, so that when we were trying to get a catheter in to get her set up for ECT, it was an extremely potent trauma trigger that replicated the original trauma and produced dissociation and hyperventilation, extreme anxiety. And we had a great deal of difficulty actually getting her to sleep. We had to use high doses of, we tried nitrous oxide, we used Versed, and we had to use such a high dose of propofol it was interfering with the treatment. At the time, I was at the University of Texas in Galveston, and I was on the thesis committee for one of our MD PhD students who was studying the anatomy of PTSD fear conditioning paradigm, looking at the role of the AMPA receptor. And so I was familiar with some of the emerging understanding of the anatomy of PTSD, although I was unfamiliar with the literature on using agents like the amytal to treat PTSD. So we developed, I was doing research with anesthesiologists at the time, so we did the procedure using propofol, which is the medicine that killed Michael Jackson, but in the hands of a useful, skilled anesthesiologist. It has certain advantages over the barbiturates in that you can titrate the dose very carefully to get exactly right to the point of relaxation where the patient's able to recall and discuss and develop an extinction memory of the original trauma. And so we used prolonged exposure therapy as described by Edna Foa. So practically what we did was in the anesthesia suite, we had her sitting in a chair and we had her rate the level of anxiety on a SUDS scale, subjective units of distress, beforehand, and then we started the propofol drip, and when we were beginning to start, her anxiety level got up around 8 or 9, and with the propofol we were able to bring it down to around 4 or 5, and then we had her describe all the exteroceptive, external, and interoceptive cues of the trauma, all the things that she remembered seeing, smelling, hearing, feeling in her body, and tape recorded the session, and then handed her a pin and had her poke herself in the arm with it, and then took the pin from her and poked her in the arm with it. And this was effective, just like the old literature suggests it was, in getting rid of the PTSD-related flashback. Okay, and I'm going to, she would occasionally have anxiety and a return of some of the PTSD symptoms, but she would just break out the audio tape and self-expose. And another symptom we treated in her was she'd never been able to have water on her face as an adult because her mother would actually attempt to punish her by attempting to, threatening to drown her and putting her head under water. And she actually had drowned a pet in front of her. So it was terrifying for her. And we were able to desensitize her to that particular trauma so that for the first time in her life at age 48, she was able to tolerate the feeling of water on her face and actually take a shower. So it's striking what you see with these results, you know. And it's also striking that such an effective treatment has gone so thoroughly extinct that I was a pretty well-trained psychiatrist. I had no idea that this was in the literature. Next slide. Oh, okay, so we did a series of about 6 patients who had PTSD, doing a variety of desensitizations, and got good desensitization across the board. Just if you look at the old literature is pretty convincing. But it's interesting that when the psychotropic agents came out about the time of the Vietnam War, there was a great deal of enthusiasm that these new ways of treating people could fix everything. And of course, we didn't have any idea of the physiology of PTSD, and there was a misplaced hope that the psychotropic agents would do everything. And it's kind of inconvenient to do a procedure. You know, it may come up in the middle of your clinical day, and it may run long, and there was kind of a stigma associated with doing things in the OR. I remember as a resident rounding with one of the senior faculty on an adolescent who was mute, a clear indication for amytal, to see if the muteness could be relieved with amytal, if it was related to some neurological cause, but he wouldn't do it. And I think it was partly because of more concerns about medical legal risk in child and adolescent psychiatry and other factors that just didn't make sense. Next slide. Okay, so this is from Ledoux studies that with fear conditioning, you take something like a tone and you pair it with something like a foot shock, and this is a rat, okay? And Ledoux was able to actually map out where throughout the nervous system does the fear memory come from. And there is one route that's the quick route in through the thalamus directly to the lateral nucleus, and then there's a slower route that goes through the somatosensory cortex, okay? And some people have speculated that when you're out walking in a garden and you see something that looks like a snake, you jump, but then a moment later your cortex reclassifies this correctly as a garden hose and your anxiety is controlled. Now, it's possible that with PTSD, people become so good at numbing and avoiding and when they are just getting their thalamus triggered, not their cortex, that they never develop an extinction memory, okay? And so then when the fear memory is triggered, then you get freezing from projection to the periaqueductal gray. And so one of the things that amytal or sedative agents does is it allows the patient to continue moving and talking, whereas otherwise they would freeze and be unable to complete the extinction memory. And then there are changes in the hormones from the paraventricular nucleus of the hypothalamus and so forth. Next slide. Okay, so there are two ways to remodel emotional memory. One is developing an extinction memory that gradually outplaces the fear memory. So if you take an animal or human that's been fear conditioned, and initially they'll have a startle response and increased blood pressure and piloerection and all things like that when they have the tone. But then as you repeat the tone time and time again without the shock, the response becomes less and less and less as the extinction memory develops, okay? Now, in 2000, it was discovered that there's another process that can remodel the fear memory called blocking reconsolidation, so that when you trigger the fear memory, it goes into kind of an active labile state, and ordinarily it becomes reconsolidated. It becomes rooted further into the semantic networks in the brain through changes in synaptic weighting. But that it is possible to block this process and like you erase a file on your hard drive, to make it so that the brain no longer will access the fear memory. And that's an area of considerable interest in research now, and I just saw an article that ketamine may help to block reconsolidation of fear memory. And I think when I talk to my patients who are taking ketamine for PTSD, they report that they'll have things that would ordinarily trigger a fear response. And some of these are the extreme flashbacks, and most of them are not quite to that extreme. They are able to recall the memory much more dispassionately without the emotional component that they ordinarily would have. So it's very interesting that this is a process, and I think maybe psychedelics, this may be one way that psychedelics work, and I also kind of wonder whether or not the excitatory abreaction might have acted upon this process too. Next slide. Now with ketamine, the main focus of the session is creating a sense of safety, as John Bowlby referred to, a secure base, a sense of security, a sense of a spiritual journey. We start with a low dose, gradually increases tolerated. With IM injections, we get a peak effect within 30 minutes, and patients are usually almost completely recovered by 90 minutes. The IM injections are just as effective as the IV injections, and I've done both, and I've seen patients who've had both, and you'll sometimes see that the IV injections are more effective. They're not. They're just a bit more inconvenient. You don't have to have the patient tied down with medical equipment, and you don't have to spend money on the equipment. Now, I got interested in attachment because I had 5 patients that I treated with ketamine who would always have a very robust response, and they suddenly had no effect when there was an issue involving attachment insecurity. So that one patient was brought to a treatment by a female aide that was their only friend, and this aide had been accepted to nursing school out of state and was going to, that was the last time she was going to be with her. Another person had learned from their wife that she intended to divorce them. And very strikingly, there was no effect at all. And trying to understand this, I began reading about attachment theory, which I didn't really know too much about, and realized that when we do ketamine, as when we do psychotherapy, we stimulate attachment networks. And that if we can stimulate a secure attachment network, then we are more likely to have more benefit. At least that's the hypothesis. Next slide. So attachment theory is the study of how we bond to one another. And this the literature began in the 60s when a guy named John Bowlby who was a psychoanalyst in London, wanted to study this with a woman named Mary Ainsworth. And a lot of separation and trauma occurred during World War II, particularly in London, where the young children were taken out of the city and left in the countryside with relatives at a time of extreme fear and stress. Bowlby also, his college roommate was a guy named Harry Harlow, who studied so-called imprinting behavior in rhesus monkeys. So he was interested in it from an animal behavior standpoint. And also he was, like many of the upper class in England at the time, he was taken from his family about age 8 or 9 and sent to what they call public schools in England, but are actually private schools. They're very harsh places where physical and emotional abuse is typical. They did this using a very simple paradigm where they would take a mother in a room with a 3 or 4-year-old child, and they'd have a stranger come in the room, and the mother and the stranger would play with the toys in the room with the child, and then the mother would leave the room for about 5 minutes and then come back. And they simply recorded what did the child do during the period of separation reunion with the mother. And they found, surprisingly, that they could identify 4 patterns of behavior that were reproducible, in that when they looked 6 weeks later, they tended to see these same patterns of behavior. And in fact, when they followed up several cohorts 20 years later in their 20s, there was still a correlation between childhood patterns of attachment-related behaviors and what was seen in adults. Okay, and the attachment system is something that we've evolved, like the rhesus monkey, to forge and maintain a bond with the caregiver. It doesn't have to be the mother when we're very young. Of course, if we can't do this, we're going to starve to death. Okay, and if we're lucky, we have the right genes and the right environment, we can have secure attachment. So like 2/3 of the children in this situation, when the mother left the room, the child would fuss a little bit, but then settle down, reach out for her when she came back in the room, get picked up, rapidly soothed, and there was this nonverbal communication between mother and child that was obviously healthy. The other 1/3 of the time, the children had insecure attachment. One form was called hyperactivating attachment or preoccupied attachment. One problem with this literature is there are several terms used for the same thing. In this situation, the child fussed and cried during the entire period of separation from the mother, became even more emotionally aroused when she came back in the room, and took quite a while to settle. Bowlby and Ainsworth speculated that maybe this was a strategy for being more successful at getting help in situations where the caregiver was slowly or intermittently responsive, that you learn to overactivate the attachment system and you get more emotional pain, and the behaviors that are related to and in adulthood, this comes out as abandonment fears and a lot of anxiety in relationships. Another form of insecure attachment was just the opposite of that. It was called deactivating attachment. In this situation, the child seemed not to notice when the mother left the room and would actually turn away and crawl away and resist being picked up. But if you measured cortisol and epinephrine, they were elevated. So the child was obviously stressed. So then they speculated that here, of course, genes are a factor here. Some children are just uncomfortable being held. There's this thing called sensory processing disorder that just the sensation of the tag in the back of the shirt is uncomfortable and things like that. But also they speculated that maybe this occurred in situations of neglect, where the child learns to shut off the attachment system rather than to remain stressed by crying and crying and crying and not getting help. And I've actually had a patient tell me that they remembered a time when they just decided that there was nobody to help them but themselves, and so they stopped crying. And then the third type was uncommon in children, but I see it a lot in adults. It was an approach avoidance conflict, or a mixture. And these were children that would do things like begin to approach the mother but then freeze and fall down, turn over. And this occurred in situations of where the caregiver was emotionally unstable, unpredictable, or even abusive. So we're still wired to connect, to get help, but we do it with sympathetic arousal and getting an escape behavior, okay? And we have both, on the one hand, a need for closeness and intimacy, on the other hand, a fear of closeness and intimacy. So the attachment system becomes the backbone of emotional self-regulation. This is an important network that's involved in how we control our moods. And Peter Fonagy and others, Anthony Bateman, have emphasized the role of mentalization in this process, that just as children internalize the baby-ese that mothers speak to their babies worldwide, that over many repetitions of being cared for, from even right out of the womb until later on in life that we gradually develop this skill, mentalization, where we're able to put ourselves into the mind initially of our primary caregiver and understand what they know or want, or so we can predict and get the best care. And eventually this becomes the foundation of our rich social life that we have far more than any other animal. And then in some sense that we are able to go from having to have the caregiver physically present when we're stressed, hungry, frightened, so forth, to being able to run a copy of Mom 1.0 software in our brain and soothe ourselves. And there are conditions where this doesn't occur. Okay, autism being one. Autistic patients are notoriously, that's really kind of the main selective cognitive deficit they have, is an inability to mentalize. And psychotherapy, including psychedelics, activate these attachment schemas, and we see it actually coming out during therapy. Next slide. So this is kind of the square that often is used to represent attachment pattern. So here's the secure attachment pattern, where we're comfortable with intimacy and autonomy, okay? And this is associated with a positive model of self and a positive model of the other, okay? The preoccupied or hyperactivating attachment is associated with a negative model of the self and a positive model of the other, okay? And the dismissing or deactivating pattern is associated with a negative model of the other and a positive model of the self. Okay, so that the situation we tell ourselves that we can handle anything that comes our way and nobody else can help us. And in the fearful or disorganized, when we have an approach avoidance conflict, we have both a negative model of others and a negative model of ourselves. Okay, now how does this manifest itself in clinical practice? In St. Louis, where I did my training, there was a psychiatrist named Jerome Kriesman who had a unit where he treated patients with severe borderline personality disorder, which, as we know, is one of the most severe debilitating conditions that people can have. And it's not very amenable in most cases to medications, although sometimes medicines can be somewhat helpful. And one day, one of his patients came into the emergency room with a double-barreled 12-gauge shotgun with the tip duct taped to their head and their thumb on the trigger, and walked up to the triage nurse and said, would you please get Dr. Kriesman on the phone? I'd like to talk with him one more time before I commit suicide. And this really clearly demonstrates the three cardinal features of that aspect of, which can be a manifestation of complex PTSD. The intense emotional pain that calls for the immediate presence of a strong helping figure at that moment to help soothe them. The anger and rage that goes along with having that need, and the mentalizing problems that the patient had, didn't connect with all the other people in the room that were obviously terrified, that had to evacuate the emergency room and were frightened that they would get killed. Next slide. So one of the things that happens with treating trauma is that when you trigger the fear memory, you also trigger the attachment system. Okay, and if you have an attachment style or schema that is insecure, you're not as adept at self-soothing or self-regulating your emotion. You're more susceptible to anxiety and depression. So this is output of one of the scales that I use to measure this, the experiences in close relationship scale. And this is a patient, this is where I see a lot of patients that have the disorganized or fearful avoidant attachment, that have both a need for intimacy and a fear of intimacy. And with treatment, gradually this improves, okay? But it often takes a while. And it doesn't improve as rapidly as PTSD symptoms, which with ketamine tend to go away for a period of time, just like the depression. But I think as we do this over time, we gradually remodel the insecure attachment into a secure attachment schema. Now, there's actually some fMRI studies that have shown different forms of anatomy associated with the insecure attachment style, so that's kind of interesting. Next slide. So the clinical relevance of the attachment system is that it's the backbone of emotional self-regulation. It's co-activated when we experience trauma or threat. It's associated with mentalization, that in the type of psychotherapy, mentalization-based therapy has been developed to work with this. There's a book called Addiction as an Attachment Disorder that calls to mind that when we have an addiction, like to alcohol or drugs, in a sense we are relying upon the drug or alcohol as a surrogate attachment object, that we're using it to self-soothe rather than relationships. And the process of recovery involves leaving that method of self-soothing and forging the emotional bonds and ties that typically are absent with severe addiction, so that we are soothing ourselves the way that we did in our hunter-gatherer past, where we would spend all day long with each other, managing each other's emotions. Okay, and then also, one of the books I have on, it's a very good book, it's only like $35, but it's a good thick book. It's good, by Brown and Elliott, called Adult Attachment. And they talk about something called higher power imagery, or ideal parent imagery, that revisiting and revisioning using imagery scripting therapy, traumatic events from childhood, and rescripting what happened. In a sense, this kind of goes along with AA's discussion of a higher power. And when you think about it, when you call to mind a higher power, those who have belief in higher powers or theistic religions, they are calling to mind a strong attachment figure all the time to be there, make them feel safe during times of trauma. So in a sense, if you think of it, whatever else it is being kind of like a meditation technique that it helps to self-soothe, and maybe it makes some sense. Next slide. I think I'm running short on time, so I'm going to try to run through this very quickly. So very often we'll see a combination of complex PTSD, major depression with atypical features. In atypical depression, patients have not the insomnia and weight loss that we see in melancholia, but carbohydrate craving, weight gain, hypersomnolence, leaden lethargy, and a reactive mood disturbance, that their mood is influenced excessively by abandonment and things like that. This is often a type of depression that we see with a bipolar disorder. When you add in the impulsivity that goes along with ADD, then you've already gotten well into the 9 criteria for borderline personality disorder. But if it's a combination of those two conditions, then separately they have a pharmacology that might be treated a little bit more quickly. And then there are several forms of psychotherapy that have been shown to be helpful with borderline personality disorder. The most widely available is dialectical behavior therapy, but there's mentalization-based therapy, schema therapy, and Kernberg's transverse-focused psychotherapy that have been shown to be helpful here. Next slide. So with ketamine, the targets for psychotherapy are, I pay a lot of attention to attachment nowadays. The conditioned emotional responses, the anger, shame, fear, the avoidance behaviors. Avoidance behaviors are particularly a factor in the deactivating attachment patients. These are patients that, if they're an alcoholic and they get under stress, the first thing they do is they stop talking to their sponsor, and they stop going to meetings, and they stop paying attention to their own minds. They stop mentalizing with their own minds, and before you know it, they're drinking. Okay, so you have to tell them that that's a risk. That's how you're going to relapse. Schemas, mindfulness skills. There's something called compassion-focused CBT that gets into working on the attachment system somewhat directly. Paul Gilbert's developed this. And then the life narrative. And life narrative is very powerful. That major changes in the life narrative often occur in the recovery from substance abuse, for example. That a person goes into recovery and they may have been a meth dealer, and they have to raise a child, and they have to reorient their life 180 degrees and make a different story of their life. Okay, next slide. And this is something that happened during my first session with ketamine with Dr. Eli Kolb. I had this vision of this peninsula that was covered with a network of interconnected lights. And the ketamine told me that each node in the network was a human life. And I thought about all the suffering involved in our lives, and the connections between the lights represent the fact that the purpose of this suffering was to forge us to connect with one another, to develop compassion, and to develop our bonds and connection with others. And certainly I've taken that as a lesson that has had a major impact on how I see my life narrative. Next slide. So if we're going to, when I was at Baylor starting to do ketamine in 2007, I had exactly the same idea that maybe ketamine could be paid for by altering the reimbursement for narcosynthesis. I called around to every government agency I could find at the time, and finally a lady at the Center for Medicare and Medicaid Services told me that there's no government agency responsible for promoting treatments simply because they're helpful for people. The Orphan Drug Act will do that, but for common conditions like depression, there's nothing besides the profit motive that will propel a treatment onto the market. And she said that every 6 months, the public can lobby CMS to alter the reimbursement rates for treatments, and I think that's what's going to take. Is that perhaps if we could get a broader, I mean, the description for narcosynthesis is pretty non-directed about which medicines can be used. And in the past, some stimulants were actually used as part of it, methadone, I think, with it. And so that if the reimbursement rate could be altered for that, then that would be a huge step toward getting psychedelic therapies available. You know, I think ketamine being broadly available as an anesthetic agent is something that I've been working on very hard, trying to get it out there, trying to provide it for insurance, trying to get insurance companies to cover it, which is not at all easy to do. But anyhow, so there is something called the Center for Medicare and Medicaid Innovation, and I'd encourage you all to write Jasmine Thomas, who's the associate for the director, Mr. Adam Bowler. That's her email address there, and encourage her to consider adopting a broader base of treatment that would embrace these forms of therapy. And there's a number to call. Okay, thank you.
Ask a question while we change the slides here.
I have lots of questions.
Okay.
Do you know of any insurance companies that have started to cover? I mean, are there exceptions?
Well, you know, our strategy was to try to bill for a half hour, an hour of insurance. The problem being that as a psychiatrist, we are reimbursed to do 15-minute med checks, okay? So our reimbursement is much less for doing an hour doing ketamine than it would be for seeing 3 or 4 patients in that hour. So we actually end up losing money every time we do ketamine. Medicare does some reimbursement for ketamine, but you have to realize that ketamine is such a safe drug that, you know, it's used to sedate children for radiological procedures or in podiatry and, you know, things like that. That the reimbursement for that is not very great at all. We get some reimbursement from Medicare. We don't get any from Medi-Cal at all. And I recently had a patient with this terrible pain syndrome called complex regional pain syndrome that was getting relief from ketamine and got a letter from Medi-Cal that they just weren't going to cover it. And I'm going to try to talk with the...
You know, I know a situation where like USC is beginning to offer ketamine.
Yes, I know.
And they offer their own insurance plans.
Uh-huh.
And so I'm, you know, saying, well, if you offer your named insurance plans and you're offering it at your medical center, why doesn't your insurance cover it?
Yeah. Yeah, and it's...
You know, they say, oh, well, we're administered by a third party.
Yeah.
Or so, you know, I'm talking
Yeah.
to people
Yeah.
different. But,
Double speak, yeah.
But it seems to me, you know, that's one place where universities can be, well, if you're going to offer it and you offer your own insurance plans, why don't your own insurance plans pay for it?
Yeah, that's exactly right. Steve Richheimer actually has treated this patient, and she got, you know, a period of remission lasting, you know, a couple months or more with a series of ketamine infusions, and nothing else has worked. And if you look at the literature on chronic complex regional pain syndrome, ketamine is well known to cause, you know, several months of remission. But one of the criticisms of the literature is that the studies that have been done have not been adequately blinded because ketamine produces a psychedelic experience and the placebos don't. And it's crazy, you know.
Where can we learn more about how ketamine can address the attachment issues? Are you doing that research yourself, or?
I don't know. I'm doing it myself. You know, I work about 60 hours a week trying to make my clinic run and trying to battle with insurance companies and provide ketamine. So I don't really have time to write that down. But I'd recommend Elliott and let's see, it's Adult Attachment. This is just the best recent. No, it's not. I should have brought the book. I have the book. It's a $35 Adult Attachment Disturbances in Adults. That's it. And just to read about attachment theory.
So just another comment towards the insurance companies that are covering ketamine. Northern California, Kaiser actually has started a pilot program. So
Yeah.
if you're,
But it's closed.
Yeah.
And they're not talking about reopening it.
I wondered about that because I heard that too, and then I talked with Phil Wolfson up in the Bay Area, and he said they were still doing it. So I don't know what the deal is, but I have a friend in Hawaii who
I've called them a lot of times recently, and they said it's closed to new patients and that there isn't funding and blah, blah.
you know, my suspicion is that probably ketamine is the only treatment that works, and they're doing it in a way that is so expensive that it's they prefer to not provide it
Yeah.
as a maintenance therapy than despite the fact.
They said that they were doing it as a program, and they said they were doing it as a clinical trial.
Yeah.
Like they did.
Yeah.
There was a lot of doublespeak around it. Even my psychiatrist called them and talked to them about it.
This is a big problem. You know, I just learned of the first psychiatrist in the VA that's going to attempt to offer ketamine in the VA. I mean, come on now. Pain, addiction, PTSD, depression. You know, it's a no-brainer that ketamine should be available in every VA clinic in the country. But institutions are particularly rigid. You know, I had a couple slides about this last time about the difference between mechanical systems and living systems. That organizations and institutions tend to think that they run like a clock, or they should run like a clock, and don't willingly adopt ketamine. When I was doing ketamine at Baylor, I was seeing these remarkable results with patients that had ECT and didn't respond, that responded to ketamine. And I would round with these two other psychiatrists who would see these same patients and see the same results, but neither one of them had any interest in doing ketamine. And I finally left because there was such stern resistance in doing it in any type of institutional setting.
Why do you think that is?
Well, I think it's in part, I had a slide before of a picture of a cat and a clock, okay? And when Descartes kind of initiated the scientific method, he was doing things like dissecting animals. And he noticed that parts of the animal, like say your hip joint, are mechanical, just like the clocks and mechanical animals were popular in the royal court at the time. And he sort of brokered an agreement with the church that the physical world, res extensa, shall be the domain of science, and res cogitans, the mind or soul, shall be the domain of the church. And ever since then, that's the way science has progressed, by making mechanical models, which are technically linear dynamical models of phenomenon. The reason being that they're explicit and they're predictable and they're simple. Okay, so they can put an airplane up in the sky and make it fly, but they're not so good at predicting things like the stock market, or the growth of a city, or how a family functions, or how your mind works. You know, these are all examples of nonlinear dynamical systems, which are intrinsically unpredictable. And the idea that everything should work like a clock is still a very strong implicit model, even among scientists who know that that's not the way reality works, even at the quantum mechanical level. But it's also saturated our legal profession, where we think that blame or tort can be assigned, and that that everything should work on the basis of rules. That's why hospitals have policy and procedure manuals this thick, so that when they're sitting in front of the plaintiff's attorney, and the attorney's saying, "Now, why did you do that, doctor?" They say, "Well, look on page so-so of the policy and procedure manual. It says that this is what we do." As another example, one of the conditions that affects newborns is respiratory distress syndrome. When a newborn is too premature, their lungs don't develop. And the best treatment for that is actually a welding gas. I think it's nitric oxide. And the few brave pediatricians that were doing that were saving lives. But of course, the hospital administrators were nervous about facing the plaintiff's attorney and saying, "What did you do to this 3-pound baby? You had them inhale welding gas," you know. And finally, somebody went out and bought up all the suppliers of nitric oxide and sold it back to hospitals as a medical treatment, and it became adopted. But the idea that underneath this all is a science called diffusion of innovation theory. Okay, and if you're trying to get Peruvian villagers to boil water to prevent river blindness, okay, it's a problem if they believe that the fire demon will inhabit the water and jump into their body when they drink it. Okay, that there are many things that impact upon whether or not a treatment succeeds or even goes extinct, like narcosynthesis, and good treatment that's gone extinct, that have nothing to do with how useful it is for patients. Okay.
Thank you.